As you all know, treating a patient on mechanical ventilation involves a team. It is not only the doctor who does it. You need a nursing staff, a physiotherapist. Sometimes you may need anesthetist for help for difficult intubations. You need the you need the dietitian. So there are a lot of people who are actually involved. So suppose you see a patient, a ventilated patient in your ICU. So what all will you do in your daily assessment? So first you will have a look at the patient. Then you will check at the monitor. Then you will see the ventilator. Then you look at your chart. How are the blood pressures? How are the hemodynamics? How are the ventilated trends? And how has been the patient over a period of time? That is the trend. Then you look at some of the investigations like X-ray, blood gas, and reports. And after all these things, you make an overall impression. So how is the patient? Whether he is stable, he's improving, he's worsening. And after that, you sort of make a plan. So what to do for the patient. So here you can see, this is a boy who's been put on ventilator. As you can see here, like the boy is in bed, you have a lot of monitors, the ventilator, infusion pumps, tubings, so many things which are connected to the young boy. So what are the things will you assess in him? Like as you already discussed, first thing, if you look at the child, you have to see where the tube is fixed at and whether it is fixed appropriately. So the tube fixation and position is very important. So like for pediatric, if you see internal diameter into 3, that will be the distance at which the ET tube has to be fixed. For example, if it is a 5 size tube, it has to be fixed at a length of 15 centimeter. And you'll have to ensure that the fix is appropriate. Here you can see this dynaplast is going till the preauricular tag. I mean the preauricular, the angle of the, till the ear. Sometimes if the ET tube is not fixed properly, there is chances that it can get displaced. So it is very important to see if it is fixed appropriately. And one more thing to notice, how much of length is outside the oral cavity. Sometimes this length may be too long. Even in this patient, it is slightly long. So in such cases, you can cut the ET tube because all this increase the resistance to airflow. And you'll have to check if the ventilator tubing is appropriate, it is not soiled, the connectors are appropriately connected. You usually have a ET tube. So all patients, invariably pediatric or adult, should have a cuffed ET tube. So you'll have to ensure that the cuff is inflated and measure the cuff pressure periodically. So this is what you do in the child. And once you look at the monitor, so there are different modes which can be set in the monitor, which we already been discussed in your earlier classes on mechanical ventilation. So these are the parameters which you set in the ventilator, the lower half of the screen, and you get the information on the upper half of the screen. So whatever is set here is being delivered or not, you can have a check here. And this is a graphical representation of the same. So this you look in the ventilator. And you also always look at the blood gases and the X-ray. In X-ray, there are 3-4 things which you have to look at. So usually you have a look at the heart. How is the heart, whether it's normal sized, enlarged. And you look at the lung fields, whether they're clear or is there any opacity. In this child, you can see the lower zone is opacified on the left side. So probably this child has maybe a collapse or a consolidation here. And tubes and lines. Always ensure the ET tube is in right place. The right place for the ET tube is, tip of the ET tube is in the between T2 to T4 or 0.5 to 1 centimeter above the carina. So that is the classical position. One more way of looking at it, it should be in between the clavicles. If it is above the clavicle, it is way high. If it is below, much below it, it is probably endobronchial. And one more thing to remember in the ET tube is, ET tube always follows the position of your neck. If your neck is kept flexed, the ET tube will appear as if it is deep. When you extend your neck, it will appear as if the ET tube is high. So whenever you do an X-ray, you ensure that the ET tube, your neck position is neutral. It is neither not flexed nor extended. And all intubated patients should have an NG tube. Here you can see the tip of the NG tube sitting in the stomach because to decompress the stomach. If there is no NG tube, the stomach will get distended and it can compress the base of the lungs and cause collapse. So all intubated patients should have an NG tube. If there is any line, suppose if there is internal jugular vein line which is present here, that can be seen in the X-ray also. So general pearls, if you see, You'll always have to check the ET position. ET position can be checked by where it is fixed. You can auscultate to look for bilateral air entry. And as I said, it is in the X-ray you see 0.5 to 1 centimeter above the carina. And it has to be fixed appropriately. It is very, very important because all intubated patients, we like to change the position of the patient. If it is not fixed appropriately, or if it is soiled due to a lot of secretions and it gets loosened, once you change the position, the tube is likely to get displaced. So it's very important to ensure it is fixed appropriately in each shift. And only cuff ET tube should be used. Either it is a pediatric patient or adult patient, it is always to be a cuffed ET tube. Okay, and you'll have to measure the cuff pressure. It should be around 20 millimeter of mercury. Maximum it can go till 25 mm. If it is more than that, it will compress the trachea and it can lead on to stenosis in the trachea. And always look for chest, auscultate and look for bilateral air entry. And another point to remember is intubated patients do not need daily X-ray. So we are of the opinion that like the child is ventilated, so we'll have to do an X-ray daily. It is not required at all. So whenever there is a problem, you do the X-ray. Like post-intubation, you do an X-ray to know where is the tube position, how are the lungs, and to titrate your ventilator settings. But they do not need regular daily X-rays. And all intubated patients should have an NG tube. And blood gases to be done as and when required. Usually it is done like 4th hourly or 6th hourly. And if there is no problem in oxygenation, you need not do a ABG. Even a venous blood gas is sufficient. Now, because we have very good monitors which can tell you the pulse oximetry saturations, so we can monitor the saturation using the pulse oximeter and the carbon dioxide using EtCO2. So what is EtCO2? EtCO2 is end-tidal carbon dioxide. It indicates that if the endotracheal tube is in the trachea or in the esophagus. If you get a EtCO2 trace, that means your tube is inside the trachea. That is confirmatory. Okay, so you can monitor the EtCO2 and get a value, approximate value of what is the carbon dioxide level in the blood. So now we are all moving towards non-invasive monitoring. Instead of doing frequent blood gases, the trend is to do pulse oximetry and EtCO2. But there are places where you may not have EtCO2 monitoring predominantly. So in that cases, you'll have to rely on blood gas. And all intubated patients should have this bedside tray, which includes first a suction catheter and a suction catheter for the oral cavity and ET tube, separate suction catheters. And this is called a Bain circuit or Jackson-Rees anesthetic circuit. Some people may not have this. Instead, you can use a ambu bag. So what is the difference between the Bain circuit and ambu bag is, in Bain circuit, you always need free flow oxygen. Oxygen should always be going in for the bag to get inflated. But in ambu, you don't need a oxygen to be connected. Even if oxygen is not there, you can ventilate with a ambu bag. You can bag with it. So, but Bain circuit advantage is you will be able to generate some amount of PEEP in it, and it will ensure that your seal is appropriate. Because while bagging and masking the patient, you have to ensure a good seal. So this will ensure this will not fill if the seal is not adequate. But in ambu, even if your seal is not very good, the bag will start inflating and you'll look as if you're giving some pressure, but actually you'll not be delivering any pressure at all. And you'll have to make sure that you have emergency medications, appropriate site laryngoscopic blades, ET tube sizes. Always ensure you have 0.5 centimeter size below and above. So both the sizes should be available here. The most important equipment in the airway trolley is your mask, not the oxygen mask, the mask which is used for bag and mask ventilation. So this is the most important item. So without this, you will not be doing anything at all if the patient crashes. So this is a very, very important equipment.